I'm saying this as a compliment. I know Donna's there from the ADA. I'm saying this as a compliment. I think the ADA has finally taken a huge leap in terms of entering the 21st century in this decade, because they've made some very important avant-garde guideline recommendations, which I really appreciate. And then we'll talk about why a cardiologist should be more proactive in terms of treating diabetes, which I kind of already alluded to. So I'm not a diabetologist, I'm not an endocrinologist, and I don't treat type 1 diabetics and such, but I really do approach the diabetic patient as a very high-risk cohort, and therefore want to be very assertive about minimizing their risk. So I don't really have to go over the definitions of diabetes in this group, but their criteria would be based on A1Cs or based on fasting glucose levels or postprandial glucose levels. So that therefore represents the definitions of diabetes per the most recent ADA guidelines. In my practice, I tend to use A1Cs and fasting glucoses. And this is a summary again of the recommendations in terms of the benchmarks for the definition of diabetes. So it's a big problem, and diabetes, type 2 diabetes in particular, has become a bigger problem because of this obesity epidemic, which is really quite a problem. So in 2015, about 10% of the population had diabetes, and that doesn't even count the ones who are underdiagnosed. So what we're seeing is that by the time you approach adulthood, the percentage of seniors who are diabetic represent about 25%. Part of this is related to insulin resistance, part of this is related to apoptosis or cell death of the beta cells. And there are a lot of new diabetics, and it's the 7th leading cause of death in the United States. So it really does represent a major healthcare, public health care issue. So we talk about the 7th leading cause of death. It also tends to live with other comorbidities. So oftentimes the diabetic patient has hypertension, has dyslipidemia, has chronic kidney disease. And what does that do? That really means that these poor diabetic patients are taking 8, 10 medications because of each of these issues. And how well are our patients complying with these medicines? That's always a mystery. In my practice, I think it's high, but I may be fooling myself. So one of the problems with diabetes is that it cohabitates with a lot of other comorbidities, therefore a lot of other treatments, and then the question is one of compliance. So diabetics have higher cardiovascular mortality rates. They really do represent a coronary and cardiac condition. Rates of hospitalizations for these patients are higher. The development of heart failure in these patients are higher. Amputation rates for these patients are higher because of peripheral arterial disease. So you can see that it's easy to connect the dots between diabetes and cardiovascular issues. So alluding to the point, this is the Pinnacle Registry. This is a registry of cardiologists. This is an outpatient registry. And this is data published about 2.5 years ago. And it's actually pretty pathetic. So it really talks about kind of how well we are practicing medicine, out in the, in a large area. This is the United States. And what was shocking is that the use of statins, this is by cardiologists, among patients with type 2 diabetes was less than 40%. And that's pretty pathetic, actually. And I think if you did similar data looking at optimal treatment of hypertension, et cetera, you'd see similar situations. So here we go, and we beg the insurance companies to approve expensive drugs like SGLT2 inhibitors or GLP-RAs or PCSK9 inhibitors, yet we're not even really good at getting the basic things. And there are certain geographic areas actually where it's even worse, particularly in the South, in the rural areas where patients are incredibly undertreated for two reasons. One, oftentimes the physicians aren't even making recommendations. And oftentimes, especially in the rural areas, patients are not as well educated and therefore are very non-compliant.
Norm, for the people in the back of the room, could you just say what that red slide says? The red part.
The red part? So what we're looking at basically is being able, what percent of the population of patients within the registry at LDLs below 100, which is really the recommendation for LDL modification in the diabetic population. And you're looking at really, if you're looking at a series of cardiology practices, and what you're finding is, this is actually the patients who are achieving that benchmark. So you can see that it really represents as a very large proportion of, and each line represents, I think, the group of practices, but you can see in terms of the average, you're really not being able to achieve high levels of compliance with basic guidelines.
That's just such an important point, and I just want to say that we're not in the MScQA collection of data currently. They're not collecting the LDL 100. I know Tony DeMaria and other cardiology leaders in the Right Care Initiative are trying to get that collected again, because what the RAND scientists showed us, Dr. Ellen Fremont had to leave, but he was a big leader in this, is that by very closely working the LDL 100, blood pressure 140/90, and hemoglobin A1C less than 8, we were able to rapidly reduce heart attacks. So thank you for bringing that specific data.
And I think Patty mentioned that if you do look in your handout, the one with the 3 pages, you'll see how LA County in the middle is doing with respect to blood pressure, hemoglobin A1C. No, I know you're not hemoglobin A1C.
How well is it? So
Yes, so
I don't have that information.
Okay, it's between like 50 and 70%. So we're really still somewhat substandard when it comes to some of those measures, just to throw that in. Sorry.
No, I appreciate it. So I think here we are, we're talking about in an era of innovation, and I'm known as an early adapter, so I'll Carol's associates probably hear from me more than others, but in terms of wide populations, we're still talking about undertreatment with basically generic drugs. Now, there's something about diabetes and hyperglycemia. I mean, it just doesn't affect cardiovascular outcomes, but there's something about cancer deaths are higher, the higher your fasting glucose levels, non-cancer, non-vascular deaths. So there's something malignant about the hyperglycemic milieu above and beyond diabetes, which is why I think the prevention issues, weight loss, caloric restriction, as well as exercise are so incredibly important.
I'm sorry to make you back up to that slide again, but if people can't see it is the problem. So I looked at this for about 15 minutes on the plane on the way down, this one slide. Could you just talk about that critical data? I mean, the relationship with cancer, vascular death, all-cause mortality.
So what we're looking at is, basically, on the x-axis, you're looking at mean fasting glucose levels. This is in millimoles per liter. What's the conversion? Is it about, I think it's about, was it 40 to 1, something like that? But anyways, this is you're looking above a threshold that as your glucose levels go up, as you go from left to right, so does the hazard ratio or the risk. So 1.5 hazard ratio would mean 50% higher than your benchmark. And I think that, so it's clear that cancer-related deaths, it's clear that non-cancer, non-vascular death. So there's something about the hyperglycemic condition. A lot of this may be related to obesity. We find that in obese patients, they have a higher incidence of cancer and cancer-related deaths. So I can't connect the dots in terms of telling you exactly why these patients, is it glucose or is it some other metabolic abnormality that's closely associated with hyperglycemia, but there's certainly a relationship between these two situations, between overall mortality, cancer mortality, non-cancer related non-vascular mortality as glucose levels go up. So it's a malignant disease, diabetes. It really, I think that's why I'm assertive with treatment. So the point I had made it early on in terms of lowering A1C levels, insulin, sulfonylureas, which actually we regard as cardiotoxic, the DPP-4/1 inhibitors, even metformin. None of these drugs which reduce A1C reduce cardiovascular event rates. And in fact, some people felt, well, maybe glucose, because if all you had to do was lower glucose, then that would work. You lower glucose, give someone insulin, you get their A1Cs down into the sixes or what have you, that therefore your cardiovascular events would be reduced, but that really wasn't the case. So some people felt that maybe it really wasn't, glucose was kind of more of an innocent bystander, or it was, so perhaps was a marker of morbidity, mortality, but not actually the cause and effect. And so what we did as cardiologists, and we focused on lipids and hypertension and these other comorbidities, and didn't really look at, as well as lifestyle modifications. And for us, A1C wasn't, as long as it wasn't off the wall, as long as we weren't talking about A1Cs of 8, 9, 10, we felt, well, there's nothing really to be done, and the trials looking at tight glucose control were actually not, the outcomes weren't very good because of the incidence of hypoglycemia, which is actually more dangerous to a cardiac patient than hyperglycemia. So we had a lot of available therapies, which each have their own metabolic or their own pharmacologic effects in terms of different organ systems. So you can see, for instance, the SGLT2 inhibitors, they block the reuptake of glucose in the proximal tubule. You have the TZDs, which certainly, which I still use actually, increase lipolysis. You have the GLPRAs, which have their effect by slowing gastric emptying, as well as having an effect on the appetite center. So you have all these different therapies, and they all affect glucose metabolism through a variety of different mechanisms, which is why you can add layers of these therapies and still get incremental reductions of glucose or A1C. So metformin is still #1 on the ADA list. In fact, even for patients with cardiac disease, it is #1. And there's 2 reasons why I think, or perhaps 3 reasons why metformin is still listed as #1, but the data with metformin is actually quite thin. It's based on 400 and so patients from the UK PDS trial. It was an obese subpopulation of diabetics. That was the only population where metformin was actually able to achieve a reduction of cardiovascular events. But the reason why I think metformin is still #1 is #1 is generic, so it's inexpensive. #2, it is associated in some people with some weight loss, so you may get a drug that leads to some modification of insulin resistance by virtue of weight loss. And of course, all of the comparative trials looking at these new compounds, metformin was basically used as a background therapy. So we don't see trials, for instance, comparing metformin to an SGLT2 inhibitor. What you see is metformin plus an SGLT2 inhibitor, for instance, compared to metformin alone. But so it still remains #1 in terms of the ADA recommendations for those reasons. Interesting that use of metformin with a sulfonylureas was actually associated with reduced survival. As a cardiologist, we do not like sulfonylureas. In fact, I look at, when a patient comes to me on a sulfonylurea, to me it's a quality of care benchmark. It tells me that they're just they're in not just another decade, but they're in another century. So I'm known as a sulfonylurea slayer. You don't want to do anything good, don't do something bad. The TZDs took a bad rap based on a meta-analysis that was published by the folks at the Cleveland Clinic. I actually did with Dr. Peter McCullough the first reanalysis of the data that was published, and found actually that this issue of the TZDs and cardiovascular, actually causing cardiovascular harm, I think it was the first fake news in the medical literature. I think after that was the immunization issue. So what we found actually, that if you didn't have heart failure, the TZDs were great drugs. They actually have effects in terms of insulin sensitivity. They have effects in terms of one of the few drugs that has an effect in terms of reducing hepatic steatosis. So there's some multiple effects. So the TZDs still remain in my armamentarium. In fact, a trial that doesn't get much play these days, the proactive trial, actually evaluated pioglitazone. And what was unfortunate was that the primary endpoint, in clinical trials, the primary endpoint doesn't reach a statistical significance. The trial is considered a failure. The primary endpoint in this particular trial was all-cause mortality, non-fatal MI, stroke, acute coronary syndrome, endovascular surgical intervention, and amputation above the ankle. So it did have a 10% reduction, but the p-value did not achieve significance. But the more important endpoint to me as clinical cardiologist was the secondary endpoint, which was pre-specified, was a composite of all-cause mortality, non-fatal MI, and stroke. And that was actually cut by 16% and with a significant p-value. So to me, they made the endpoints wrong. That should have been the primary endpoint. So pioglitazone in particular actually, to me, is somewhat cardioprotective as long as you don't have heart failure and you don't have fluid retention. So then you have the DPP-4 inhibitors. They're quite potent in terms of reducing A1C, somewhere between 1 and 1.5. There are a number of them. I don't think I have all of them here. The list keeps growing. All I'll say about the DPP-4 inhibitors, and they really block the breakdown of the incretins, so therefore they have a similar effect as you would see with the GLP-RAs, but not quite as robust in terms of weight loss, etc. But basically, the DPP-4 inhibitors are cardio-neutral. Okay, so basically they lower A1C, and therefore they probably have an effect in terms of microvascular disease, but they are cardio-neutral. The TCOS trial with sitagliptin was interesting because it did show what seems to be an increased incidence of heart failure. Now, just as an aside, because initially when Steve Nissen and his colleagues from the Cleveland Clinic gave us the fake news about the TZDs, the FDA felt it had egg on its face. And therefore what the FDA did is they said any new drug for the treatment of diabetes, type 2 diabetes, had to have a cardiovascular outcome trial. Okay, so they mandated these cardiovascular outcome trials because they wanted to show that these drugs were not harmful. So these, because this will have import in terms of the trials that I'm going to show you. These were not trials that were brought forth because of the marketing departments, but trials that were actually mandated to show no harm. Of course, they only looked at new agents, so they have not assessed older agents like the sulfonylureas. So let's talk, we'll get a little bit more interesting and relevant to what I do in the course of my clinical day. So we'll talk about the GLP-RAs, the glucagon-like peptide 1 receptor agonists. So they're analogs of naturally occurring the incretin GLP-1. They have long half-lives. That's why sometimes they can be given once a week. They increase glucose-dependent insulin secretion, so they make more insulin available, and they decrease glucose-dependent glucagon. So there's less glucagon, more insulin, and therefore you reduce glucose levels. They slow gastric emptying, which is why you get the nice side effect, particularly in your obese diabetics with weight loss. And they reduce A1C levels, and these are the three that are available. We're going to focus on liraglutide and semaglutide because there's clinical trial data showing cardioprotection. So remember, these were studies that were mandated to show no harm. But the interesting thing is some of them actually showed benefit. And this was seen in the LEADER trial. You'll see on the left upper part of the trial, left upper graph. And this is looking at the primary outcome, which is the usual cardiovascular mortality, non-fatal MI, non-fatal stroke. That they actually had superiority was about a 13% reduction of the primary composite event. You also see as you go towards the right about a 22% decrease in terms of death from cardiovascular cause. So now we're starting to see evidence of actually a cardioprotective effect. And therefore, the incentive for using these compounds. This is SUSTAIN 6, which is looking at semaglutide. Primary outcome actually rated for superiority. So it was superiority to placebo. Remember, placebo means that both groups were still on very good basic therapy, including statins, antiplatelet drugs, the conventional glucose-reducing drugs. Non-fatal MI was not statistically significant, but about 26% reduction. Non-fatal stroke was significant, about a 40% reduction. And in this particular situation, there was no mortality benefit in terms of death from cardiovascular cause. But we can see that overall endpoints were reduced, stroke was reduced. So we're getting a taste that, that these drugs are cardioprotective. In this particular case, with semaglutide, there were reductions of A1C, as well as reductions in body in actual weight. So these are types of effects that we would, I think, all agree would be protective. So then you also now, we'll change gears, we'll go into the SGLT2 inhibitors, and there are, let's see, 1, 2, 3, 4, I think there are at least 4 that are currently approved. Now the way these trials are interesting. So the way the drug works is by blocking reabsorption of glucose. So what you're basically doing, you're getting glucoseuria. But sodium travels with glucose and so does water. So therefore what these drugs do actually is they induce diuresis, okay? And they induce a natriuresis. So these particular drugs are associated with some modest losses of body weight, some reduction of visceral fat, as well as some reduction of blood pressure. There's really no effect in terms of lipid effects. And what we're going to do is talk about some of the cardiovascular event reduction. Now, the important point of the SGLT2 inhibitor trials, there was a disassociation between the glucose-lowering effects of these drugs and cardiovascular event reduction. So what we're seeing here is an effect of these drugs in terms of reducing cardiovascular events that's independent of actual reductions of A1C, because the SGLT2 inhibitors just are not particularly potent in terms of reducing A1C. So the EMPA-REG trial was actually the first trial that revolutionized. It was the first trial of a diabetic drug that showed a reduction of cardiovascular events, published in 2015. And that's when I got excited about, really excited about this field. So patients who were considered high cardiovascular risk were randomized to either placebo, 10 or 25 milligrams of empagliflozin. Here's the usual primary endpoint. They had a key secondary outcome, which was the primary outcome and hospitalization with stable angina. Good trial, 7,000 patients, and the duration of the trial was about 3 years. So this was pretty interesting. So what they found was over the course of the 3 years, the primary outcome, which is not super impressive, about a 13 to 14% reduction of the composite endpoint, statistically significant and met the criteria for superiority. But what blew everybody away was the death, not just from death from any cause, which you see here was cut by 32%. That's pretty impressive. You're talking about a mortality reduction, about 32 death from any cause. So you actually saw a mortality benefit, which I think, if you look at the absolute difference, I don't have that here, but if you look at the absolute difference, I believe the number needed to treat to save a life was something in the 30s. So you really had now a very potent drug, not potent in terms of A1C reduction, but potent in terms of death of overall mortality. And you look at death from, and now you're going to look at death from cardiovascular causes, you're seeing a mortality reduction of nearly 40%. This is on top of statins. This is on top of your blood pressure modification. As a cardiologist, this is huge. I mean, this is huge, okay? And what most people are finding, the death from cardiovascular cause does not seem to be a class effect among the SGLT2 inhibitors. Empagliflozin is unique. But what does seem to be a class effect among these drugs is the fact that they're renal protective and they're great drugs for patients with heart failure. So even a diabetic has edema, has an elevated biomarker for heart failure. This class of drugs is particularly useful. So they're renal protective, they seem to be cardioprotective, and they reduce cardiovascular overall mortality. And the subgroup analysis was just these plots were just consistent for basically all the subgroups having either the right trend or as a statistically significant benefit. Whether your diabetes was well controlled or not. So basically, this was consistent with the overall issues. The safety issues with the SGLT2 inhibitors is really, since these drugs do cause some diuresis, you want to make sure your patients don't become volume depleted, okay, especially if they're on loop diuretics. The other issue, is particularly in women, because you're now inducing more glucose-uric effect, is the rather common finding of fungal infections, particularly in the groin area. And now you have there's actually been reports and now becomes part of the prescribed information of still a very, very, very unusual complication. I think they call it Fournier's gangrene, which is very rare, but something that which actually seems to occur in other classes of diabetic medicines, which has also been seen in this class. But again, a very rare complication. So someone's complaining of pain in the perineum and the finding of consistent with an infection or hypoperfusion, then obviously these drugs aren't for them, and that needs to be treated aggressively. So the Canvas trial looked at, I'm not going to go through these trials in big detail. So the Canvas trial looked at canagliflozin, and what we see here is we don't see the same type of cardiovascular benefits. There's a lot of trends in this particular trial, but what we do see, the common issue we do see is this robust reduction of renal events. Remember we said renal events and heart failure were common in terms of what seems to be a class effect. And many of our patients with diabetes have chronic kidney disease. So the same issues in terms of Canvas. The little concerning thing with Canvas, however, was the increased rates of amputation. And this seems to be only seen in the Canvas trial, so in patients who are on canagliflozin, that's a caution not to use it in patients who have severe, significant symptomatic peripheral vascular disease. Declare looked at the dapagliflozin, same situation. We see that the composite effect in terms of the primary endpoint on top being about that usual 15% so reduction. We did not see the robust effects in terms of mortality, but what we did see, and what makes it pretty common, look at hospitalization for heart failure is down, as well as incremental decreases in renal, in progression of renal dysfunction. So we're really getting the message in terms of what is the class effect and what is not. But I think that this is the case. Now what's unique about the DECLARE trial is they actually looked at patients for primary prevention as well. Got it. And what they found was there were trends towards reductions. These were patients who had diabetes but did not have overt cardiovascular disease, what we call primary prevention. So if you look at just the primary prevention population, which would be the MRF, multiple risk factors, there was a strong trend towards reduction, but it did not quite achieve statistical significance, but this is a subgroup. But overall, the trial did show a reduction of events in these patients. So therefore, we are quite excited by the fact that you're actually able to get this renal preservation, no matter what your baseline renal function is, whether it's normal, moderately reduced, or more severely reduced. We don't know the pathway why you're getting this cardioprotective effect. It's under a lot of investigation. It does not seem to be related to reductions of A1C. It seems more related perhaps to changes of how the cardiomyocyte gets fueled. Perhaps it modifies the metabolism from being more based on free fatty acids to either ketone bodies or the glycolytic pathway. So we're not sure exactly why the SGLTs do, but we do not feel that it's related to its reduction of A1C. And of course, this is the graphic I love. This is from the ADA guidelines. I think this is, an incredibly important, and you should download these ADA guidelines. These are really important because I think they do give a really good review of the different effects of these different medical therapies. But again, what I've said over and over in this presentation is really GLP-RAs and the SGLT2 inhibitors, which I think give us the greatest effect. This slide's really important. It was just, it was in JAMA Open Network at the end of the year of last year. And what they did was, they looked at the incidence of the first cardiovascular event in patients, this is from a big insurance database, for patients who were on a variety of different therapies. And what you can see, it's clear that the different therapeutic subgroups give you a very big difference in terms of the incidence, and this is inpatient data, of cardiovascular event rates. And what we see here is preaching to the choir is that the GLP-RAs and the SGLT2 inhibitors seem to have the lowest incidence of cardiac complications. Again, this is kind of more like we call real-world data. We see here, looking at the DPP-4 inhibitors, kind of being in third. You see here I think this is it's hard to see in this one. I think this is probably the SFUs. Okay, and of course, so the SFUs are the ones that seem to have higher complications than the others, and I think this represents your basal insulin. Part of the reason why you see basal insulin having relatively high cardiovascular complications events is related more to the hypoglycemia. So again, this is from the most recent ADA guidelines, which I think really represent a huge advance and very, very helpful. So I refer you to that rather than going over that. I'm not going to really go over the cost, but perhaps Carol can do a better job of going over the cost issues, but there certainly are large variances in terms of cost to the patient by virtue of whether they're a government program, a non-government program, so there's certainly difference in cost. The problem is the only two classes of drugs for diabetes that reduce cardiovascular events are the ones that